a stranger's feeling, don't know what to believe in.
Called the pelvic function. The floor acts as a pelvic diaphragm. Sorry, I got sidetracked. Something about the recording. I got put in my ear. So the pelvic diaphragm has a real important role with the lung diaphragm. And if you think of it as kind of like a sump pump, the lung diaphragm and the pelvic diaphragm work in conjunction with each other to create intra-abdominal pressure. And this has a really important influence on not just continence and defecation and urination and even sexual function, but also has a spinal stabilizing function. So that's those are the functions of the pelvic floor. This is straight from my Herman and Wallace, curriculum. So let's move on. So I want to also point out that men have a pelvic floor. I think we get caught up with talking about women and Kegel's, and because Dr. Kegel's work was really with women, but men also have a pelvic floor. And I highlight this because there is a difference between the Herman and Wallace pelvic rehabilitation practitioner certification and the women's health certification from the APTA, although the APTA does offer courses in men's health. From what I know, the PRPC with Herman and Wallace is an omnibus. It covers both men and women's health. So if you have a particular interest in just women's health, then you can look at both options. But if you're interested in men's health, I think Herman and Wallace does a great job. Okay, let's look at an underactive and overactive pelvic floor environment, and what does that look like? So for an underactive pelvic floor, you're going to see low muscle tone. This is going to be a hypotonic environment. This will be a weak environment. The pelvic sling will have difficulty initiating an activation, so it will be very difficult for the person to feel like they're strong in that area. It will also be fatigable. The overactive pelvic floor will have high muscle tone. It too will also be weak. So think of your upper fiber traps, how it can feel so strong and so hypertonic and tight. It might not necessarily be, in fact, strength-wise, it feels like it's strong, but it actually is not. It's locked short. And so it is a weak environment. It may be able to initiate a pelvic floor contraction. Sometimes on assessment, we don't see that a person that is hypertonic can do this, but often will have difficulty with the release of the pelvic floor. It too is fatigable. So part of the introduction to this this talk, and even the video that was posted on Instagram, where I was sort of talking about this interplay between orthopedics and the pelvic floor. So I'm, there's many of you on this talk. I don't know what direction you guys are all going in, but I will say that there is a real relationship here that exists between looking at other orthopedic conditions and how it influences the pelvic floor and vice versa. So imbalances in the body can lead to pelvic muscle dysfunction. Imbalances in the pelvic floor can lead to orthopedic pathologies. And it's kind of like looking at what's going on first. Is it the chicken or the egg? And sometimes it's not clear. One of my first patients I ever saw was an Olympic trampoliner. Now, her whole life, she was on Team Canada, and her whole life she had been jumping. Everything in her body was so solid, so strong, yet she also presented with a condition called vaginismus. Now, vaginismus is the involuntary tensing or contracting of muscles around the vagina, preventing insertion into the introitus. And so it's hard to say what came first, but this clearly had some effect on her sexual function. And you know, we were able to, as therapists, help her through her issues using our skills and our tools. Now, imbalances in the pelvic floor can lead to orthopedic pathologies. So if you're looking at, there are many studies that are coming out that's demonstrating a relationship between pelvic muscle dysfunction and hip labral tears. So obturator internus is a strong hip external rotator. In fact, it's one of the external rotators that you guys hear about. Piriformis gets all the attention, but obturator internus is in that category of lateral rotators of the hip. And it fascially connects to the tendinous arch of the levator ani, the levator ani being the main pelvic floor muscle in the sling. And so increased tension around the obturator internus can turn hips outward or externally rotate them, putting more shearing forces on the anterior capsule of the hip joint, and that might lead to more femoral acetabular impingements, labral tears. So there is this strong relationship, and there's a lot of research coming out in this area. And so I highlight this, and I highlight the function that it would support, which is the stabilizing function. The another example is, the there's a patient that I've recently treated that has pelvic organ prolapse. Now, pelvic organ prolapse is when parts of the organs are pressing into the vaginal canal and can actually sometimes fall out of the vaginal canal. This can also happen in men rectally. So the part of the rectum can actually fall out of its past the anus, and there's different degrees and varying degrees of severity. But what we're finding is with pelvic organ prolapse, a patient might be incontinent. My patient had urinary incontinence. We can correlate it with low back pain, similar to what that sump pump function I was talking to you about. Well, if you lose strength in that pelvic sling, it's not working in conjunction with the lung diaphragm, and we can start to see aberrant forces within the intra-abdominal area take hold and create dysfunction in other orthopedic areas. It also has, I highlight some of the functions. It's not just the sump pump, but it's also supportive as well as sphincteric in this particular example. Now, for this one, it was a little tricky for me. Let's see if yes. You guys have it on your screen, right? Okay. So looking at excessive transverse plane foot mechanics and a weak pelvic floor, I've had a patient that presented like this. And it's uncertain what really came first. I'm not sure. But we are seeing foot mechanics and its relationship to the pelvic sling, and there's been some studies as well that are looking at how ankle stability is related to that. Okay. So let me go on to talk about common pelvic floor related diagnoses. So these are things that I have seen in clinic. During the question and answer period, I'm happy to talk about more case examples if that's of interest to you, but I wanted to list some of the things that if you pursue pelvic floor therapy, that you might come across. These are certainly things that I've come across in my career. So pelvic organ prolapse, which I just described. Urinary incontinence, which is a common one. Sometimes you're treating the lifespan in this situation with urinary incontinence. So you think of it more as like a geriatric problem or a postmenopausal problem. You can see children that suffer from this issue as well. We know that micturition or urination is somewhat of a learned behavior at some point. It's not just programmable. And so I don't work with pediatrics and pelvic floor, but some of my colleagues do. And it's an interesting field, looking at how these functions affect children. incomplete voiding, which is urination not to its completion, so your bladder still remains full. We talk about in our coursework, we call it jicking it or just encasing it. So have you ever been told to run to the bathroom, go to the bathroom just in case? Like we do it to children a lot, like go to the bathroom before we go down a long drive, like just in case. Well, habits can form in this environment because as I said, micturition isn't just programmed, it's also a learned behavior. And so you can see examples of where people are rushing to the bathroom continuously, or going to the bathroom a lot in a day, upwards of 10 to 12 times. And the question is, are they jicking it? Are they not completely voiding? Interstitial cystitis is a painful bladder condition. Sometimes a defect in the bladder or the bladder itself can result in issues in the bladder. So irritating substances can enter the bladder and cause a very painful condition, particularly when urinating. Dysuria is painful urination, and you can see it in many different many different diagnoses, but it's sort of more of a symptom, I would say, more than anything. Post-prostatectomy urinary incontinence, I treat men, and this is an area that they may have difficulties with after their prostate's been removed due to cancer or enlargement. So the sexual issues that you might see is vaginismus, which I highlighted with the Olympic trampoliner. The introitus becomes non-penetrable, and there are a variety of reasons why, but that's the basic diagnosis. Dyspareunia is painful intercourse. I see this commonly, actually, in women ages 20 to 30, typically, but you can see also dyspareunia in the geriatric population due to vaginal dryness and because of menopause or low estrogen environments. Erectile dysfunction, anorgasmia, which is the inability to orgasm. Persistent sexual arousal syndrome, which is a problem for those that are continuously excited or dealing with orgasms consistently to the point where it's very uncomfortable and affects their functioning. Some abdominal and gastric issues that we see. So I want to highlight here that we talk a lot about the vagina and urination. And what often people forget that pelvic floor PT can also improve gastric function, things like constipation and bloat. So the skills extend to both the GI environment as well. So we treat constipation, abdominal pain, incomplete evacuation, which means that they aren't fully defecating. Fecal and flatulence incontinence can result for a variety of reasons. Pelvic pain, chronic pelvic pain, which is more of a broader term. People can have chronic pelvic pain from a variety of conditions, but it does also have its own diagnosis, which you can see: chronic infections, UTIs, and endometriosis and PCOS. So these are all things I've treated in my clinic over the years. And the really amazing thing is, with schooling and education and continued education in this area, you can really become a very skilled therapist. But I will say one thing too, is that as you become a skilled therapist in pelvic floor therapy, I think that what's really important too is that you maintain your skills as a therapist for other areas as well, because I find the best pelvic floor therapists are the ones that can treat things outside of the pelvic floor, because nothing happens just in a silo. So if there's pelvic floor dysfunction and